Anxiety can be defined as a negative mood state involving fear or apprehensiveness that is accompanied by bodily symptoms such as increased heart rate, muscle tension, a sense of unease, and concerns about the future. But in order to properly understand anxiety, we need to remember that anxiety itself is not a disorder, nor is it even a problem in many cases. That's because a moderate amount of situationally appropriate anxiety is not just normal, it's a good thing from an adaptive standpoint. We need anxiety in order to motivate us to do things that are sometimes necessary, like avoiding danger or preparing for future trouble. One key difference between adaptive and maladaptive anxiety is whether the anxiety is situationally appropriate. It's appropriate for us to feel anxiety when confronted with a natural disaster like an earthquake or a hurricane, because that anxiety serves to keep us safe. But most situations in life shouldn't prompt us to feel very much anxiety. So if we start to notice that going to school or work every day makes us feel anxious, or hanging out with friends makes us anxious, and going outdoors makes us anxious, then maybe there's something wrong. Basically, if the anxiety is helping you to live a good life, then it's adaptive. But when it gets to the point where it's inhibiting your ability to live a good life, then it's maladaptive. Another way to gauge this is by thinking about how much anxiety you're experiencing. A little bit of anxiety could be helpful in some day-to-day circumstances. A little bit of anxiety can motivate us to study for a test or to wash our hands before eating so we don't get sick. But an extreme amount of anxiety can be debilitating. It can actually interfere with healthy behaviors. So then how do we make sense of anxiety-related disorders? Well, we can start by examining what might make people susceptible to maladaptive anxieties. These are called vulnerabilities. Biological vulnerabilities are genetic and neurobiological factors that play a role, although we don't know exactly how because there's no specific gene for anxiety. And at the moment, all we can really say is that it's heritable, so that there must be some genetic link. Psychological vulnerabilities include intense early experiences, including unpredictable stressors or traumatic events, which affect our psychological well-being and ability to handle stress later in life. This underscores the importance of early experiences in childhood or adolescence that pave the way for adult disposition. Specific vulnerabilities are more about the way that people might deal with anxiety and how it might manifest in different situations. For example, one person's anxiety level may rise when they're given a lot of responsibilities, while someone else's anxiety may grow when they're given free time and left alone. Learning in this case refers to some of the behaviorist concepts we learned about back in week 2. This can include classical conditioning. For example, little Albert was conditioned to fear small white animals after hearing a loud noise. Based on this, if we're conditioned to fear something, that could develop into an anxiety-related disorder. Generalized anxiety disorder, or GAD for short, is a persistent and non-specific tendency to worry about a lot of things. For someone to be diagnosed with general anxiety disorder, feelings of worry must be widespread and undiscriminating. People who experience generalized anxiety worry about a wide range of mundane and serious things. This refers to scope. People with general anxiety cannot turn off the worry. They worry more days than not, and this refers to persistence. And finally, general anxiety leads to several impairing symptoms such as sleep difficulty, irritability, and in some cases, inability to perform basic life functions. This refers to affect. The DSM-5 criteria specify at least 6 months of excessive worry and anxiety of this type must be ongoing, happening more days than not for a good proportion of the day in order to be clinically diagnosed. About 5 to 6% of the population in America has met the criteria for generalized anxiety at some point during their lifetime, making it a common anxiety disorder. As I mentioned on a previous slide, anxiety can sometimes develop due to behavioral reinforcement, as is the case with classical conditioning. But the law of effect and operant conditioning can also play a role, as people's maladaptive thought patterns are sometimes reinforced. Your textbook notes how some people with generalized anxiety spend a lot of time worrying about catastrophic things that are very unlikely to happen. So when those bad outcomes don't happen, an individual with anxiety might falsely believe that their anxiety prevented the bad outcome from happening. There's the example of the anxious mother who constantly frets about her teenage daughter coming home safely. And when the teenager finally does come home, she feels like the anxiety was justified and that it may have actually helped prevent something tragic from happening. What she fails to realize is that the tragedy she was afraid of was highly unlikely to happen in the first place, and her worrying about it did not have a positive impact. With panic disorder and agoraphobia, this is a state of anxiety that co-occurs with an extreme fight or flight response accompanied by physical symptoms such as chest constriction, shortness of breath, sweating, and tingling. These bodily symptoms are because the mind perceives an extreme threat to be present when in fact there actually is none. But unfortunately, rather than recognizing that there is no actual threat, our minds in this state may react to those bodily sensations with more fear. In other words, when you realize that your body is in a state of panic, your mind interprets this as, oh no, there must be a big problem. And then that results in more panic. You may be starting to see a pattern developing here with anxiety symptoms and disorders feeding on each other. People with panic disorder tend to interpret even normal physical sensations in a catastrophic way, which triggers more anxiety and, ironically, more physical sensations, creating a vicious cycle of panic. What makes panic disorder stand apart from generalized anxiety is that people with panic disorder often avoid things that they were doing around the time of their panic attack. So if they felt constricted, they may avoid tight-fitting clothing. Basically, people avoid things that produce the same types of internal sensations of physical arousal as those that occurred during the panic attack or the intense fear response. This is known as interoceptive avoidance. When people avoid environmental circumstances or situations that are similar to the circumstances they were in during a panic attack, such as avoiding certain types of social environments or buildings, this is referred to as agoraphobia. It's more about the external cues. Phobias are fear-based, but are different from the type of generalized anxiety that we discussed so far. Phobias are more specific, such as a fear of heights, fear of spiders, fear of blood, etc. It's very normal to be moderately afraid of those things, in part because they can be dangerous. Falling from heights can injure or kill us, same with spiders, and blood can signify danger or disease. Just as with general anxiety disorder, the key difference between adaptive and maladaptive forms of fear is that phobias impair a person's functioning. For example, a person may be unable to leave their home in the morning because they're so afraid of encountering a spider. Phobias are highly heritable because not only is there a genetic predisposition to specific phobias, just like with generalized anxiety, but people may lack positive experiences as children with the things that their parents are afraid of. People with a specific phobia typically have more than one specific phobia. That refers to comorbidity. And over 12% of the population has had a fear significant enough or with enough functional impairment to be considered a phobia, which refers to the heightened prevalence. Social anxiety disorder, or SAD, is similar to the other manifestations of anxiety that we've discussed in the sense that there's a normal amount of apprehensiveness that we feel about social interactions, because if they go badly, there is always the potential that we will be rejected, abandoned, or ostracized. Because humans are so ultra-social as a species, and because in our evolutionary lineage, ostracism often led to illness or death, we go to great lengths to avoid that. Sometimes in cases of social anxiety, we avoid situations that are social completely. This is sometimes preceded by a particularly upsetting experience, such as bullying or harassment. And of course, it's normal and common for people to experience anxiety with things like public speaking in front of a crowd. That feeling of anxiety might be adaptive because it keeps us sharp and motivates good performance. But when it impairs performance or when it causes avoidance of those types of situations, that's when we have a problem. People with social anxiety disorder are often unable to carry on with everyday social interactions with other people. Post-traumatic stress disorder, or PTSD for short, develops following exposure to a potentially traumatic event. I'm using the term potentially traumatic event here because research shows that the vast majority of people who experience a traumatic event do not go on to develop PTSD. This includes things like extreme violence, as in war or terrorism or assault. Most people who survive those experiences are not traumatized, but some are. When people experience PTSD, they're often constantly reimagining and re-experiencing the event itself, which sometimes happen as flashbacks, nightmares, and intrusive thoughts. Flashbacks occur when memories are so vivid they feel like they're being relived in the moment. This may cause physical responses like an elevated heart rate or sweating. There are emotional effects of this as well, such as shame and guilt and self directed anger. These recurring thoughts are also accompanied by hyperarousal, that is, being easily startled, feeling tense or on edge all the time, and having difficulty sleeping. People with PTSD often experience avoidance as they seek to stay away from places and feelings associated with trauma. This can result in depression and other forms of generalized anxiety. As we've talked about before, there is a fine line between normative psychological experiences and a disorder. It makes sense from an adaptive perspective for us to be afraid that a terrible thing will repeat itself, so we avoid similar contexts and situations. If you go to a bear cave and get attacked by a bear, you might think about that experience a lot and feel fear and maybe even dream about it, which may motivate you to stay safe and stay away from the bear caves. So the question is, when do these experiences become maladaptive? The key distinction is that people should be able to recognize when they're no longer in a situation that is dangerous, and therefore should be able to carry out their lives normally. People with PTSD have trouble with basic life functioning. For example, symptoms in veterans become maladaptive when the veterans are no longer in life-threatening situations and experience difficulty nonetheless transitioning back to civilian life. But again, it's important to remember that most soldiers, even those who have experienced the horrors of war, do not develop PTSD. And just as with the vicious cycles of other anxiety-related disorders that we saw before, we can see something similar happening here. Once an initial trauma causes an individual to believe that the world is dangerous, they feel like they need to be hypervigilant in order to avoid such dangers. But those dangers were very unlikely to happen again in the first place. So when they don't happen, the individual feels validated and their hypervigilance increases. A similar pattern can also be observed in individuals with obsessive compulsive disorder, or OCD. With OCD, a person experiences obsessive thoughts and or compulsions that seem irrational or nonsensical, but keep coming into their mind anyway. For instance, it might be normal for some people to have a thought pop up like, oh, I hope I remember to turn off the stove or lock the door, but then most people are able to move on with other thoughts. In individuals with OCD, those thoughts get stuck and won't go away. There's also an intense urge to engage in behaviors related to those thoughts, such as the urge to straighten a picture frame, such that it can cause significant anxiety if the behavior can't be carried out. This is often accompanied by a worry that something might go wrong if this small imperfection isn't fixed, like maybe the picture frame falls and breaks and hurts somebody. Furthermore, someone with OCD might become preoccupied with the possibility that the behavior wasn't carried out to completion and feel compelled to repeat the behavior again and again, sometimes several times, until they are, quote, satisfied, such as repeatedly locking and unlocking their door before finally locking it. Here we again see the vicious cycle happening with OCD. There exists a strange or irrational thought that gets stuck and becomes a preoccupation, which is accompanied by excessive worry and behaviors which are connected to an irrational attempt to resolve the worry, but instead turns into compulsions that are self-reinforcing. So hopefully by now you've seen how similar this array of anxiety disorders are, especially in terms of self-reinforcing cycles. Knowing this, the next logical question is, how do we treat this? The most effective treatments involve some form of cognitive behavioral therapy, or CBT, in which patients are taught to recognize the maladaptive thought patterns they have. From there, patients practice reframing exercises to replace the maladaptive thoughts with healthier ones, in addition to disrupting the connection between thoughts and behaviors. So, for example, if a patient with OCD is worried about germs, they might be catastrophizing, in which case it would be useful to imagine the very low likelihood of something really bad happening if indeed they do contact germs. In addition, they can remember that just because they have those thoughts, they don't have to engage in repeated hand washing or glove wearing. The patient basically needs to understand ways in which they can cope with anxious feelings without being overwhelmed. This is sometimes called increasing their distress tolerance.